Welcome to Health or Consequences, the monthly podcast focused on Massachusetts healthcare and public health policy issues that runs under Commonwealth Beacon's Codcast label. I'm Paul Hattis from the Lown Institute, and I'm here with John McDonough, my co-host from the T.H. Chan Harvard School of Public Health. And we're very happy today and timely to invite back someone who's been a guest of ours before, Lora Pellegrini, who is the president and CEO of the Massachusetts Association of Health Plans. Laura's been in that role since 2010, and she's had other roles in private health insurance and state government. We'll let her detail some of that in a moment, but we couldn't think of, in some ways, a better person to reflect a little bit with us, both about some legislative happenings in the healthcare arena towards the very end of last year, as well as what's likely to happen moving forward. So, Laura, we want to welcome you back. And can you tell our listeners a bit about yourself, about MAP, and really about your current role as MAP's president and CEO?
Thank you for having me. It's great to be back. So as the president of MAP, I represent 13 health plans and one behavioral health organization who all do business in Massachusetts. And we are committed to high quality and affordable health care. I've actually been in my position now for 15 years. It's hard to believe. It'll be 15 years this month. And prior to this job, I was a vice president at Harvard Pilgrim in charge of government affairs. I've also worked for 2 governors, so I've seen policy making from the inside. And I also served as an assistant attorney general in the Consumer Protection Division.
This is John. Welcome, Laura. Great to have you. You've been a real valuable and knowledgeable player in Massachusetts health policy for so long, so we really appreciate it. Since you represent the insurance industry, at least the non-Blue Cross part of the insurance industry in Massachusetts, and in December, there was the horrific shooting on the streets of Manhattan of a United Healthcare executive, and then a surprising, noticeable managed care insurance backlash as a result of that took over the whole nation for a brief period. I'm wondering if you have any thoughts or reactions to that before we get into the Massachusetts substance and put those events and the controversy in the context of Massachusetts.
Sure. So I think the murder of Brian Thompson was awful, and murder is never the answer, right? Ever. I think with Luigi Mangione, I've done a lot of research on this. It seems that, and it may come out soon, that his beef was more with corporate America and not particularly with United Health, although I think he thought they were an example of a very large corporation in our country who's in different segments. I think United's reported that neither he nor his parents were members of United Healthcare. You know, I often say that people experience healthcare through their healthcare premiums, right? And we've seen those costs going up. And I've worked really hard during my career to try to bring everyone to the table on the affordability question. I like to say that health plans can't fix the affordability question alone. We'll get into this probably a little bit later during this conversation. We've been huge supporters of the Health Policy Commission. And the reason is because they, for the first time, were able to really put some context around what are driving healthcare costs. And premiums are really just a reflection of what are driving those costs. And today we know that is largely what we're spending in hospitals for inpatient and outpatient care and in the pharmaceutical industry. So everyone needs to be a part of this conversation. I do think that the United shooting was larger than just the health insurance industry, but we can't ignore what we saw on social media. And so I'm a big proponent and wanting to educate people about the things and the protections we have in Massachusetts for consumers. John, I think you were a part of this when you were serving the legislature, but we do have very, very strong protections in Massachusetts for consumers to ensure that they're getting the care that they want and deserve. And health plan premiums are highly regulated. Our profit or surplus is highly regulated. We'll probably get into that soon. It's probably the most regulated in the country. So that should give consumers some confidence. And we're also folks in the state are largely covered by the not-for-profits. I represent both for-profit and not-for-profit, but most of our citizenry is covered by not-for-profit health plans. And their mission really is to support the community. So I think those are all important points.
Okay, thanks for that context, Laura. Very much appreciated. So let's switch to Massachusetts. So in the final days of the 2023-24 session, I think surprisingly, the legislature finished work on two bills that it had been digging into for the full 2-year session. And they're both significant in terms of Massachusetts health policy. Can you tell us what, from your perspective, you believe were the most significant and important features in those two bills, whether they're good or whether they're not so good?
So I will say, John, you also have been an observer and participant in state house politics. I was probably one of the few people who would say to my staff and say to our members, a bill's never dead until it's dead. And I sort of had a sneaking suspicion that this was going to happen. So we were prepared. I want to take an opportunity to applaud the Speaker, the Senate President, Senator Friedman, and Senator and Chairman Lown of the House for getting these bills over the finish line. Many of the provisions we'll talk about are things that we were trying to accomplish for a long time, and they got done. And they actually had a very productive session, with these two bills being very illustrative of some of the work that they did. So let me start with, I think the pharmaceutical and PBM accountability was something we were trying to do for a long time, make them a part of the Health Policy Commission's cost trends hearings and make them provide data to the commission. That is something, again, was not part of the original law. As we started to see drug spending increase, we saw that there was really a need to bring them under the umbrella as our providers and health plans. So I think that was a huge feat. The Office of Pharmaceutical Policy and Analysis will really allow us to get under the hood to understand drug spending, how rebates work, how volume discounts work. I think there's been a lot of finger pointing between the PBMs and the pharmaceutical industry. And I think letting the HPC sort of get under the hood to really understand those transactions and how it relates to list price, et cetera, will be super important. In the bill, there's a strong determination of need provision. And I think in the original law, basically DPH could approve a project before the HPC had acted with their state report. I think this says, no, we need to wait for the Health Policy Commission report and before the Department of Public Health can act on a DON, and they need to consider the cost and any of the statewide planning components that the HPCs analyze. So I think that's important. There are some technical changes around material change notices and an expansion of that authority, which I think the HPC was looking for. There's a statewide planning component that I've been talking about for 15 years, so it's nice to see that. And then the primary care task force. I think MAP has been a strong proponent of encouraging and advancing primary care in our state. Within the cost benchmark, that money needs to come from existing money in the system. And so hopefully that task force can begin to start to unravel some of that. I think what's missing in the bill is anything really around affordability and cost containment. We'll probably talk more about that, but I think that is the number one issue facing the Commonwealth. I also would have liked to have seen the determination of need process moved exclusively to the Health Policy Commission. I think they have the expertise on that. And then there was a provision which got a lot of attention, which caps copays on drugs. And I think we could all agree that if folks have chronic conditions, we would want them to be able to access their drugs and not have cost be a barrier. I think our concern with this provision, it is going to increase pharmaceutical spending by about 1%, we calculate. But what we've already seen as we start to look at dockets for the bills that have been filed in 25, which was my fear, is that you open the door to no cost sharing, no copays, and you're going to see a lot of other drugs that people are going to look to have covered under those same provisions. This bill, and I suspect some of the bills that are being filed for 2025 have been promoted by the pharmaceutical industry. And I like to say, I think that what they want to do is have you go to the counter at the drugstore and pay nothing for drugs. And so you walk out thinking drugs are cheap. It's great. I paid nothing. I paid zero. It's wonderful. When we know they're one of the key drivers of healthcare cost and they're the fastest growing sector. So I think legislators, I think on the chronic disease piece, I can understand why folks wanted to do that. I would just ask that they work with us to not expand this, because again, that is my fear, that this gets widely expanded. And what's going to happen is premiums go up. I think there's a lot of misunderstanding about how we build a premium. The Division of Insurance has been having these listening sessions to try to really address how premiums are developed. And I've seen the pharmaceutical industry recently message, well, the health plan set the premium. We do set the premium, but it's based on these underlying components, and drug costs are a key component, and we really need to get a hold of that.
Great, thank you. So we've had some big laws pass in Massachusetts on health policy. 2006, the Universal Coverage Law. 2012, the law that created the Health Policy Commission. So we know landmark laws when we see them. Would you put this in the category of landmark, or would you say this is probably something good, solid progress, but much more is needed to try to achieve the challenges of where we are today?
I think it was good, solid progress. I think there's an important foundation that they laid, and I think they deserve a lot of credit. It's not easy. The pharma, having pharma and the PBMs be part of the Health Policy Commission process seems like a no-brainer. It's been really hard to get that done. It's been years in the making. The determination of need and the material change notice provisions have been really difficult to do. So again, foundational, I don't think it is landmark. I think what could be landmark, and I hope it's our focus in 2025, is around cost containment and the affordability issue and really taking that on. We're falling behind other states. I know people bristle at that in state government. It is true. You just have to look at laws in other states to know it's true.
What's your hope for this new statewide health planning process?
I think we really, want to take an inventory of what we have. And I think, my fear has been, and I think it's played out, that when hospitals and others are looking to expand, they look at things that are going to be profitable to them and not necessarily what the community needs. And I think that our state needs to do an inventory to understand what we need. God forbid that we ever face another Stewart crisis. But, I think it's important to understand emergency room capacity, urgent care capacity, what we have for diagnostic testing in regions, and that we are promoting projects that are in the public interest and not just that are profitable to the players.
Lora, let me follow up with you're raising the issue of and concern of commercial affordability, actually a concern that many of us share. And there was not a lot in these two bills about that. However, there was one interesting provision that seemed a little bit out of the blue, where the State Department of Insurance was given a stronger role in reviewing commercial health insurance contracts, looking at issues of both pricing and affordability. Could that make a meaningful difference, possibly at all, in affordability from your perspective?
Well, they didn't give the health plans any tools to make healthcare affordable. So let me just back up maybe and just tell you, I think what we have done as a state for years is try to address the affordability question on the backs of the carriers. So we have the highest medical loss ratio standards in the country. 88 cents on the dollar needs to go to medical care, the rest to administration and surplus. That is far higher than what the ACA requires. If plans make more than 1.9% surplus, they can have their rates rejected. The other actors in the healthcare sector have no cap on surplus or profit. We have very aggressive rate review. That's part of the Affordable Care Act. We have folks at DOI. We have federal money, I think, in place to bring in actuaries to really scrub through health plan rates to make sure that they are proper and that there's not an unjust margin, if you will, built into it. And then they added recently public information sessions where plans have to go and explain why their rates are what they are. No other sector has this. And in 2010, I think my litmus test is when the governor rejected health plan rates, the plans that took those cases to appeal actually won their cases because it was found that while the rates are high, they were actuarially sound. Today, most of my plans are losing money. They've lost money for several quarters. And you could argue in theory, they're actually not collecting enough in premium, which is not a popular message. So this provision, what it says is that the commissioner will now consider affordability, but the rates need to be actuarially sound and solvent. So I think much like 2010, you're going to find that while we don't like the rates, they're high, they are what are needed to support the underlying cost, which are provider cost and pharmaceutical cost.
Do you think there's any enhanced ability of DOI to look under a rate filing, let's say at a specific contract from a provider and say, gee, that seems unduly high of a rate increase and not necessarily going to approve that particular contract, or do you not see that as a power that the DOI would have under this new law?
I mean, that would really be stretching their authority, and it's interesting. I think what the plans would say is they would need a statutory default rate. So if you had a contract with a provider that DOI determines that contract's unreasonable, we're not going to approve your rates, go back and get a better contract. There's a good chance, and if you just look at the dynamics that are going on today between the payers and providers, the provider would say, I'm not signing that contract. I'll be out of network to you so you can pay me charges. So I think the legislature would have to put a default rate in place. Would they be willing? Again, we're falling behind other states in what we're doing on cost containment. And so we really would have to see the legislature really dig down deep to be able to make those kinds of changes for the good of consumers, really for the good of consumers. So I'm not sure that would totally work without a default rate. And I think it really could create chaos without that opportunity, because I just think those providers would be out of network. So I would say too that I think this affordability standards, like we're half pregnant here, I think they were trying to adopt a standard that we're seeing in Rhode Island around affordability. But they did, as my previous comments, we've wanted to have this affordability conversation and cost containment conversation on the back of the insurers without being willing to really engage other providers in the system and other players in the system. Rhode Island has a provider rate cap. There's a hospital rate cap in their law that is missing from this. So basically, you're telling the plans to do the impossible and create magic. And we're not going to be able to do that. Again, as I said, our plans, they are lucky if they make a 0.5% profit surplus. Most of my plans are in the red right now, significantly in the red. And this is the most challenging time that I've experienced representing them, given their financials.
So we're in a new legislative session, 2025-26. What are you trying to get done this year? What's MAP's agenda that you're carrying forward that you hope you'll see success on in the next 24 months or so?
As always, we have been talking about affordability and cost containment. This is becoming the number one issue, I think, for the state. The governor's budget's coming out today. I think, you'll see the mass health spending is growing. And I think that's the number one issue for them, and certainly for our employer community. It's a really important issue for Massachusetts competitiveness. We filed bills to rein in facility fees, to require site-neutral payments, and to set a state default rate for surprise billing, having the plans pay an average in-network rate. If we were able to do those things, we would save billions of dollars. We're also looking to cap services that are beyond 200% of Medicare with a strong default out-of-network rate. And this is something that the HPC has modeled. I think getting away from capping particular providers, capping services whose prices are 200% of Medicare or over would make a lot of sense. I think we need to push the envelope here, prescription drug affordability, having a prescription drug board. This is something that Maryland's doing. I think Colorado's doing. I think that is pushing the envelope. I believe some of the drug companies or pharma are suing the states around this, and this would set an upper payment limit. If we had a prescription drug board that would look at some of our highest cost drugs and set an upper payment limit. I think we need to push the envelope. I think we're at that point that we need to be doing creative things. And John, as you know, sometimes the best ideas come from the states. And I think we really need to be in Massachusetts an incubator for some of this change. And I think that's how we did health reform. And I think we need to be doing that on cost containment. It really is, when we did our healthcare law and covering everyone, I think we were all very supportive of that, but we knew the next piece of this was cost containment. We, developed obviously the cost benchmark, developed the HPC. That was like half the story. It's now time we need to do more, because we know that we've got the highest cost in the nation. We pay our provider community among the best in the nation. I think there's a misunderstanding about that. They're among the highest paid. So I think it's time now to do this next phase of cost containment. So those are some of the bills that we are supporting this year. We also want to take the electronic medical record. Each system, hospital system, has their own electronic medical records, and we want to be able to aggregate that across all systems so that no matter where you go, your electronic medical record follows you. I think from a patient safety perspective, from a cost perspective, it's really important. When you're sick and in the hospital, you're not a healthcare expert or a physician, it's hard to really explain when you're not feeling well or a family member's not doing well, what their medical history is. So to be able to have that electronic medical record available can, I think, help with patient safety, but also do away with duplicate testing and a lot of unanswered questions that occur today.
We've heard the Governor Healy mention primary care as her leading health policy objective for this year. Senator Cindy Friedman has made the same comments. Where do you sit in relation to what appears to be a crisis of primary care availability in the state?
We have been very engaged in those discussions now for a few years, and we've been working actually with the primary care physicians who have been pushing legislation. We are very supportive. Primary care is the backbone, I believe, of our healthcare delivery system, and we need to ensure that people can access primary care. The issue is, where does the money come from? And we believe that money exists in the system. It needs to come, if we're contracting with a hospital system, it needs to come from other parts of the system to support primary care, and it needs to be within the cost benchmark. And so I think the big sticking point has been, I think some want to create like a special trust fund for primary care. I'm not sure how that works with existing employment relationships. And I think what makes the most sense is directing the plans and providers to do this work within the confines of existing contracts, ensuring that primary care is getting an increase, and understanding that that money would probably come from elsewhere in the system and needs to, again, be within the cost benchmark.
That would take possibly even mandating, because a lot of the monies flow to an overall healthcare system, that underneath it they reallocate those dollars to the primary care folks, right? Otherwise, you're just giving them more money, but not assured that the money will end up to support primary care.
Right. So that would be a key thing that we would have to ensure through an audit or, something, whether it's a plan audit or an outside audit. I also should say that one of the things we actually filed this year was a bill that would say that we should, and this goes again to the affordability and cost containment, that no legislation should pass that's going to increase healthcare premiums until we all meet the cost benchmark. There have been a number of bills this year that have passed that have added billions of dollars to healthcare spending, unfortunately. And again, John, not to pick on you, but as a former legislator, it's easy, right, to want to pass things that make your constituents feel good, et cetera. But making that link to raising healthcare premiums, I think, is really important. So I'm thinking about some of the mandates. We talk a lot about wanting to help small business, and I talk until I'm blue in the face to people. I'm not sure they're still getting this. Large corporations do not have to cover the state mandates that pass, but small businesses do. So the very people we're trying to help, we're adding additional costs to them. And that's really unfortunate. We have very comprehensive coverage in the state. And so I think we have the most mandates of any state. So, I think legislation like that, a moratorium on healthcare legislation that's going to add to healthcare cost and premiums, might be something that's really needed right now, because we're not doing well with the benchmark, right? We've missed it, I think, 6 out of 10 years.
Laura, we really appreciate your thoughtfulness on a state perspective. But before we let you go, given that this is a few days into a new Trump administration that we're recording this, are you hopeful about anything in particular coming out of that new administration in Congress, as well as what's your greatest concern right now from a federal perspective?
I'm very concerned about so many things, both in healthcare and beyond. I'm really concerned about what happens with the Affordable Care Act. You hear that they won't repeal it because some of the red states actually have benefited from it. But I think we saw in the last Trump administration efforts to dismantle certain parts of it through regulation. So very concerned about that. And then, of course, everything that we've done in our mass health program through our 1115 waiver, et cetera, I think I'm very concerned. There was an article this morning that there's a policy paper circulating among Republicans around block grants that would be very harmful to Massachusetts and the gains that we've made. So I'm very nervous. It's hard to believe that we're living in this time right now, seeing the things that are going on.
So I'll throw one little wrinkle in there, something that started in the last Trump administration and that is proceeded quietly. It's called ICHRA, or Individual Coverage Health Reimbursement Arrangements, is starting to take off. And it's a way for employers to stop buying health insurance and to give lump sum money to their workers to go and buy it on their own. Are you hearing that in Massachusetts at all? Is that getting on your radar screen? Because it is in other parts of the country, I know.
Yeah, I have not, and I think it's something that we should dig into. What we typically had heard is that employers wanted to provide coverage. It's something that distinguishes them, right? To have a nice benefits package to present to a prospective employee. And as I think we struggle in Massachusetts to keep, employees here, we always heard that, they want a comprehensive set of benefits for their employees. So I've not heard that, but I wonder for small business if that isn't something that they would consider. So it's something I think we need to watch closely.
I think it's something very much to keep our eyes on, for sure. So Lora Pellegrini, thank you, CEO and president of the Mass Association of Health Plans. Thanks for being part of our podcast today, and good luck in all the challenges and difficult times ahead. Thank you. We'll be back again next month.
Thanks for having me.